So this is 2024 Neurosciences Test 1. Alright, so question 1 says which type of receptor is primarily responsible for detecting light touch? And here the answer is the Messner's corpuscle. Nociceptors, these ones pick up pain sensations. Thermoreceptors are for heat. Pacini and corpuscle, this one is for pressure and vibration. So I had mentioned to say pain, touch, and temperature actually travel through the same nerve. When you look at the A delta, which carries acute fast pain, transmits these three types of modalities. So if you injure yourself, you start rubbing the area, you are creating some heat, and that touch, you'll feel a bit better because there is a competition amongst the three modalities. So question 2 and 3 will use this figure. So when you look at the parts that have been labeled here, first thing first, you need to be able to know the parts that make up the spinal cord. How do you tell that this is the front part of the spinal cord and this is the back? Anyone that wants to give it a try? How can you tell that we are dealing with the front part or the back part of the spinal cord? Anyone? So when you see what we call the ventromedian fissure, this fissure that is here, that tells you are in the front. Because at the back we only have a small and space and we call it a sulcus. And again, when you look at the front, when you look at the horns, these horns, they don't go much, but at the back they reach to the end like that. Okay, so the spinal cord, just like the brain, has got gray matter and white matter. The only difference is that for the brain, the gray matter is outside, the white matter is inside. But for the spinal cord, it's opposite. It's the white matter that is outside and the gray matter is inside. And when you look at the gray matter or the spinal cord, we have got what we call the central canal here, and that's where we can divide the spinal cord. In front of the central canal, that's the anterior aspect, and then at the back we have got the dorsal. So for the white, for the gray matter that is on the middle, we have got the horns. We have got this one, we call it the ventral gray horn, and then we have got the dorsal gray horn. On some segments of the spinal cord where we find the autonomic nerves, like between T1 and L2, those regions also find the lateral gray horn. So we are basically saying that A is the ventral gray horn. Now B is representing a tract that goes from the brain to the spinal cord, which we call the corticospinal tract. The corticospinal tract. Okay. Cortical represents where it's coming from, spinal where it's going. So every time they ask you identify for the following whether it's ascending or descending, you just look at the name. If it's ending in spine, it means that you are going to the spinal cord, so meaning you are descending. So the corticospinal tract is going to have the, because this tract comes from up going downwards, it is going to be a descending tract. But at the same time, you also have some other tracts that are ascending in nature. For example, I've got the, which one? The spinothalamic. This one starts from the spinal cord. It's going upwards, so spinothalamic. So it's going from the spinal cord upwards. All right. Okay. So we have identified the tract already in this case. That's the corticospinal. So question 2 is saying the result of lesion A is best defined as. So what happens if there is injury to the anterior aspect of the spinal cord, or the ventral gray horn of the spinal cord. When you look at the brain, let's say here is our brain like that. We have got a neuron that will move from the brain up to the spinal cord, and then we have got a neuron that will pick it up from the spinal cord to your muscle or your organ. We call this as the upper motor neuron, and then this is known as the lower motor neuron. So if there's a lesion to the upper motor neuron, there are specific features that you'll be able to see. And if there's a lesion to the lower motor neuron, there are specific features that you'll be able to see. So lesion to the upper motor neuron, most of the reflexes are going to be increased. So we're going to see hyperreflexia, like the reflexes are going to be over exaggerated. You are going to see hypertonia. The tone is going to be exaggerated. Like if you're trying to pull someone's hand, it is very hard to pull. The tone is exaggerated. They more become rigid. Other things that you'll be able to see for someone that has got an upper motor neuron lesion, you'll see what we call the Babinski sign, which I think you've done in clinical skills. When you use, say, a patella hammer, and then you start rounding under the feet of someone, you see the way they are going to move their toes. Okay, like the toes will be able to face upwards. That's the Babinski sign. Another thing that you'll be able to see, of course, we said that the muscle tone is going to be increased. So there is what we call spastic paralysis. Someone is going to become spastic. Okay. In lower motor neuron lesion, the opposite is going to happen. For the paralysis, it's known as flaccid. When you hold the hand, it can just fall as though, something that is flaccid, is flappy. So you hold the hand, it will just fall like that. That's the meaning of flappy. That is in lower motor neuron lesion. Okay? I hope that makes sense. Another thing that you'll be able to see in upper motor neuron is that there's going to be muscle groups are going to be affected, because the neuron on top doesn't just control one muscle down, it controls a lot of muscles. For example, someone might have what we call hemiplegia, like nearly hemiplegia is where half of the body is really not functional. Okay. In lower motor neuron lesions, you normally affect a single muscle group. I hope that is okay. So an example that we can give in upper motor neuron lesion, you have got stroke. In lower motor neuron lesion, Bell's palsy. So the result of lesion to A is going to be what? So we are saying A is the anterior ventral horn, or the ventral gray horn. So this is where you are going to have the lower motor neuron lesions basically to come from, going to the muscle or whatsoever that they are supplying. So if there is injury to this part of the body, there's going to be flaccid paralysis. Is similar to injury to the lower motor neuron. Does this make sense? Yes, please. Okay. So when you look at the descending tracks, the important ones are basically the descending tracks. You divide them into two. You have got the okay, yeah, they are divided into two. We have the extra pyramidal and the pyramidal ones. So when you look at the extra pyramidal, you have got two types there. You have got the corticospinal and the corticobulbar. And then you have got now the others, the extrapyramidal. Most of them, really, they are going to be short. They end somewhere just in the brain. And then for the ascending ones also, unless the ascending ones, that's where you have got a lot of them. But I think there are diagrams when you look at them for these tracts. All right. When you look at their location, you'll be able to tell. You can actually identify which portion of the spinal cord you expect to find a tract. For the corticospinal, it is a bit more specific on the location. Okay, on the side of the spinal cord. But if we're discussing the ascending tracks, you have got a lot of different ascending tracks that will also be found somewhere where you can see this tract. So what is important is just you being able to look at a diagram and then being able to identify which tracks are found in which region. For example, if it is the ascending tracks in this somewhere in this region, you are going to see what ascending tracks here. You'll be able to see the spinothalamic. But remember the spinothalamic, you have got the lateral and the anterior. So anterior will be somewhere here. And then the lateral is going to be somewhere here. The spinothalamic, also known as the anterolateral system. But for the descending one, the important one that goes down to the spinal cord is the corticospinal, because the corticobulbar is controlling the upper part of the body, so it ends in the brainstem. Does that make some sense? Okay. Number three is saying the result of lesion B is best described as. So when you look at B now, that is injury to the cortical spinal tract. What do you expect? The Dysphagia of movement, flaccid paralysis, impaired two-point tactile discrimination, spastic paralysis. Okay. So when you look at the corticospinal tract, what does it control? So this guy is going to control muscles, right? It's going to control muscles. And if there is injury, basically you need to understand what is the main function, in other words, of the corticospinal tract. What is the main function? So the corticospinal tract is actually, when there is injury to it, the lesion is going to be that of upper motor neuron lesion. Why is it so? Because for this tract, you are coming from the brain, and then you are coming down to the spinal cord, and then now information is going to be picked up from the spinal cord going now to the muscle that you are trying to innervate. So it's actually lesion to the corticospinal tract is going to be similar to the lesion of an upper motor neuron. So there is going to be spastic paresis. Paresis is basically paralysis, right? It is spastic in nature instead of being flaccid. So there's going to be increased muscle tone, there's going to be hyperplexia, and these other signs that are involved in upper motor neuron lesion. Hope that's okay. Please, if it's not, feel free to ask. Number four is saying, sorry. Okay, these nature movements, just uncontrollable movements. Now, when it comes to movements that you cannot really control, you, you you have got in the brain, you have got what we call the basal ganglia. So the basal ganglia, the function of it is basically to coordinate movement. And what happens that when you plan a movement, before you do any movement that you plan, let's say for example, you say, I want to pick this cup. Before you pick that cup, the information is going to flow from the cortex going to the basal ganglia. Of course, we'll discuss that later on because it's a topic. The basal ganglia has to modulate that function so that you don't overextend your hand to try to pick that cup, and then you can be able to pick it. But before you pick it, information has gone from the cortex to the basal ganglia. It has to be sent back to the cortex, and then now the information is going to go to the muscle that you want to be able to stimulate. So in this case, if there is injury to the corticospinal tract, really it's not about uncontrolled movement. Is that okay? All right. Number four is saying which pathway carries information about fine touch and proprioception to the brain. spinothalamic tract, dorsal-column medial lemniscal pathway, corticospinal tract, rubrospinal tract. Anyone that wants to give it a try? Feel free if you want to give it a try. B, all right, good. So the dorsal-column medial lemniscus pathway. Yes, please. Someone has a hand up? Or they wanted to say something. Okay, so when you look at the ascending, it's important for you to understand this also. When you are looking at the ascending pathways, you have got the main two ascending pathways. You have got the spinothalamic, also known as the anterolateral, and you also have the dorsal column. Now, for the dorsal column, you have got two. You have got the fasciculus cuneatus and fasciculus gracilis, depending with which part of the body you're talking about. If you are below T6, think of the gracile muscle, the gracilis muscle that is down. So below T6 is going to be the fasciculus gracilis, above T6, fasciculus cuneatus. And really, the dorsal column medial meniscus pathway, this one is going to be there for touch, fine touch, vibration, and proprioception, basically balance. When you look at the spinothalamic is for pain, temperature, and crude touch. But remember, the spinothalamic tract, you have got the anterior spinothalamic tract and the lateral spinothalamic tract. So you should be able to differentiate which one is which one is going to pick what sensations, right, between the lateral and the anterior. And it's also important for you to understand where exactly do these tracts get to decussate in the spinal cord. So when you look at the lateral spinothalamic, is the one that will carry the pain and temperature. The anterior carries basically the touch and the pressure. Touch and pressure. Well, you can try to remember this using a tap. Hope that will make you remember instead of confusing you. The tap there, I've got the T being touch, the P at the end being pressure, and then the A in the middle being anterior. And then for the lateral spinothalamic tract that remains is going to be for pain and the temperature. Hope you not confuse the P in the tap for pain. It's pressure, right? And so when you look at that's for the corticospinal, the lateral and the anterior. And it's important to understand that for this tract, immediately it enters the spinal cord, it quickly decussates. So if this is a spinal cord, this tract is coming from this side, it will quickly decussate and then start going this side. So meaning that if you injure the spinal cord on the right side, the sensations will be lost on the other side, contralateral. And what sensations does this guy carry? The same touch, temperature, okay? The touch, the crude touch, temperature, and also pressure will be lost the other side. It's different for the dorsal column, which carries proprioception, because for the dorsal column, this guy is going to enter. It will be going to the same side until you reach the medulla. That's when it will be able to decussate. So if you injure the left side, the sensations are going to be lost on the left side. Why? Because decussation doesn't happen at this very point. Decussation happens up in the brain. Hope that is okay. So you should be able to tell that if there's a lesion and be able to explain which side the effect is going to be seen. The rubrospinal tract, this one is starting from the red nucleus, and this is in the brainstem coming down. And the function of the rubrospinal tract is basically for coordination of motor function. Which neurotransmitter is most commonly associated with pain transmission in the spinal cord? Dopamine, serotonin, glutamate, acetylcholine. Anyone that wants to give it a try for this one? What do you think? Glutamate, excellent. So glutamate is the main excitatory neurotransmitter in the central nervous system. So if glutamate is released, there's going to be pain. Dopamine is normally, this guy is involved with things to do with when we'll be discussing, there's something known as Parkinson's disease and also psychosis. The people that we say they are mad. Okay. So dopamine is very important in that it's involved in reward and also movement. Parkinson's disease, you have got dopamine being a bit of low, because Parkinson's disease and in psychosis, these two conditions are basically opposite. Because in Parkinson, anyway, let me not discuss Parkinson's. You see, in Parkinson's, you have got two neurotransmitters, acetylcholine and dopamine. Actually, it's going to be opposite because acetylcholine is going to be low, dopamine is going to be high. So that creates these abnormal movements. Okay. And then for serotonin, serotonin is also going to modulate pain, but it is inhibitory. For acetylcholine, you know most of the autonomic functions because it's released in most of the areas. A chemical messenger that is released by a neuron into circulation. So this word circulation is important, and which may exert its effect on a distant peripheral target targets is known as this distant. What do we call that? Neuromediator, neurohormone, neuromodulator, neurotransmitter. What do you think? Very good. So every time you're talking about an hormone is released into blood. Remember last year in physiology we did discuss the exocrine glands and the endocrine. We call them endo because we release into the hormones into blood. Exocrine, there is no blood involved. You just release them via a duct. Okay. So that is the neurohormone. Hormone, it's always about circulation. Which type of nerve fiber are primarily involved in transmission of sharp acute pain? A beta, A delta, C, and the beta. Which one do you think is the best option? Any thought? The A delta, excellent. Okay, A delta for fast sharp pain. And remember, these guys are myelinated, that's why they are even much faster, and they've got a very big diameter. The C fibers are unmyelinated with a small diameter. These ones carry dull pain, chronic pain. Which part of the thalamus is involved in relaying somatosensory information to the cerebral cortex? Ventral posterior nucleus, medial geniculate nucleus, lateral geniculate nucleus, anterior nucleus. Any thought for this one? Excellent. The ventral posterior nucleus. So when you look at the way information comes from down, when you are looking at the ascending tracks, so you are going to have information coming from down, right? Going via these ascending tracks. The information will first go to the thalamus. When we start discussing the spatial sensations in neurophysiology, you realize there is only one sensation that goes direct to the brain without going through the thalamus. There is only one. So you are going to go to the ventral posterior lateral or to the ventral posterior medial. But for the ventral posterior medial nucleus is normally for the information that is coming from the face via the trigeminal system. The ventroposterolateral is the information that is coming from the rest of the body via the spinothalamic and the dorsal column. The middle geniculate nucleus, will understand it when we discuss the auditory, like the hearing mechanism. It will relay information, sound basically, from the inferior colliculi to the auditory cortex. Remember, inferior colliculi is concerned with hearing, the superior is concerned with sight. So the lateral geniculate nucleus, therefore, is going to relay visual information. Okay, it will send the visual information from the retina to the visual cortex. The anterior nucleus is involved in the limbic system. Limbic system is a system that is involved with different functions like learning, motivation, emotion, all right, such things. It's going to be interesting topic to discuss. So it's ventral nucleus. Number 16 is saying all the following are descending motor tracts except rubrospinal, spinotectal, reticulospinal, corticobulbar. What do you think? Which one among these is not a descending tract? Anyone? Spinotectal, excellent. Remember again when you are naming the descending and the ascending, if it's descending, descending starts from the brain to the spinal cord. So the name should end with the spinal cord at the end. Okay? So you have got rubrospinal, corticospinal, reticulospinal, and all those with spinal. You also have the corticobulbar, but it is also descending. It's just that it doesn't go to the spinal cord. That's why it doesn't end in spinal. Because the corticobulbar and the corticospinal are the two pyramidal tracts, extrapyramidal tracts. And these guys, uh, one is going to control the facial muscles. Another one is going to control the muscles, the rest of the muscles. So it only ends in the brain, the corticobulbar. Clasp knife spasticity results from a lesion in the ventrocorticospinal tract, ventrospinothalamic tract, lateral corticospinal tract, lateral spinothalamic tract. Anyone who wants to give this one a try? So when you talk about this clasp knife spasticity, remember spasticity, that just is telling you that this is actually a lesion to the upper motor neuron, okay, or a tract at least that is upper. So that leaves you, so meaning that you are going to remove the spinothalamic because this is an ascending tract. We're talking about spasticity. There is basically no supply to the muscles. That's why there is this spasticity. It's not a sensation. It's a motor control. So the answers that remains therefore is ventrocorticospinal and lateral corticospinal. Remove the spinothalamic because those ones are sensory. Now specifically the cleft knife spasticity. This one there is injury to the upper motor neuron, and so what is specifically it affects the lateral corticospinal. Remember, what does the lateral corticospinal do? It carries pain and the temperature. Remember, the anterior it is touch and pressure. So this lateral corticospinal tract has been injured. And the way you it's named the clasp knife, specifically the way the symptoms are really are. So there's going to be spasticity that is going to be first high and then sudden dropped. So there is spasticity is basically resistance. Okay. When you're trying to extend the limbs, like straighten your limbs, there's a very big resistance at the beginning, and then the resistance gets to drop. And so the name, the clasp knife spasticity, because of the lateral corticospinal tract. Hope that's okay. If there is no, if there's a question, please feel free to be able to ask also. Number 18 is saying which ion is primarily responsible for the depolarization phase of action potential. Depolarization. Which ion causes depolarization? Physiology. Anyone? Okay, excellent. Sodium. and it's a sodium influx. What is a primary role of the sodium potassium pump in neurons? To generate action potential, to maintain the resting membrane potential, to release neurotransmitters, to facilitate synaptic transmission. So this pump, of course, we know is for the maintenance of the resting membrane potential. During a neurological exam, a patient cannot feel a pinprick on their left foot. Okay, so here is this bro, like that. So on their left foot, this is going to be right, this is left. So if you prick them, they can't feel anything this side. Okay, which pathway is likely affected? What do you think? Which pathway is affected if you can't feel a pinprick in your left? So I've got the left dorsal column, right dorsal column, left spinothalamic, right spinothalamic. Any thought? In other words, if they press, like they prick you, you are not feeling pain. Okay. So in other words, which tract carries pain? Now, the right spinothalamic. Okay. So when you look at these tracts, the spinothalamic will carry pain, temperature, and also crude touch. Dorsal column, of course, will also include things to do with balance. Now, when you look at the spinothalamic, because it quickly decassetes immediately, all right? So if you have got this tract, remember it's on the left. So if this is a nerve coming from this part of the body, when you are going to reach the spinal cord, coming from the injury here is where, okay, during, you can't feel on the left. This is the left. When this tract enters the spinal cord, it quickly decassetes. So if you can't feel on the left, it means that injury is actually on the right because the tract quickly decassetes. So that's why our friends have said it is the right spinothalamic. And then number 21 is saying a patient experiencing tingling and numbness in their right arm after a stroke. Okay. A patient experiences tingling and numbness in their right arm after a stroke. Which brain region is most likely involved? Left primary motor cortex, right primary motor cortex, left primary somatosensory cortex, right primary somatosensory cortex. So remember again, the problem is the right arm. So which part of the brain do you think has been affected? Any thought? Okay. So yes, in a stroke, when the fibers are coming, like I think we did mention this when we are discussing head and neck. This is the one side of the brain, this is the other side of the brain. Fibers coming from this side will go like this and then control this side of the body. So if for the face you can't have sensation this side, it's the opposite side of the body that has been affected by that stroke. Okay, because of this decassation. So this patient has got problem on the right arm, so it is the left primary. Okay, what are we talking about? It's numbness. So when you are talking about numbness, that is a sensation, it's not motor. So the answer is left somatosensory. Okay, motor, unless if we said they were not moving the muscles. A patient reports a loss of vibration sense in their left leg. Remember, this is vibration in their left leg. Which part of the somatosensory pathway is mostly likely affected? Left dorsal column, right dorsal column, left spinal thalamic tract, right spinal thalamic tract. Which one do you think is going to be the answer here? Left leg, and it is vibration. Which tract carries vibration? The dorsal column. So if there is injury, excellent. Okay. So if they can't feel vibration in the left leg, it means that it's the left dorsal column, because for the dorsal column it decussates way up in the medulla. So meaning that if you can't feel on the left side, injury is likely on the left side of the board. Please, if you are not understanding this, be able to ask so that we explain again, so that if a question comes in another way, you should be able to still work your way through. All right. 26 is saying, yes, please. Yes. So, yes. So, for the dorsal column, sensations are ipsilateral. If there is injury to the spinal cord, always ipsilateral. Because if this is a spinal cord, information comes from this side of the body to continue going to this same side of the body. And then later on, in the medulla, that's when it gets to 10. So meaning that if I injure this part of the spinal cord, if I follow through the nerve, it is that same side that will not be able to pick up the vibration. So it's ipsilateral. For the spinothalamic, it is contralateral. Okay. But the injury should be in the spinal cord. Because if the injury is up in the brain, let's say you injure there, it means that the loss is going to be contralateral, because by that time decussation has already happened. Makes sense, right? Yes, the left dorsal column. Okay. 26 is saying, according to the principle behind the use of opioid antidote in the management of opioid overdose, which of the following statement is correct? Overdose on opioids is less likely to occur after a patient goes through detoxification and rehabilitation, but abuse opioids due to reduced receptor sensitivity. B is saying the preferred opioid antidote used are partial agonists at mu and other opioid receptors, where morphine is an agonist, hence reversing morphine effects. C is saying preferred opioid antidotes are full antagonists at mu and other opioid receptors, where morphine is an agonist, hence reversing. D is saying in opioid overdose, patients' pupils are pinpointed, they have respiratory depression and are unconscious due to the activation of only one opioid receptor. Which one do you think is the answer here? So we have got some drugs for the opioids. We have got different ones. We have got things like morphine, codeine, tramadol, pethidine, naloxone, all those. So when you look at all these, they cause normally dependency, because they cause euphoria. They'll make you to feel nice. That's where they abuse. Heroin is abused, also known as dimorphin. So, if someone is dependent on opioids, you give them another opioid but has got less abuse potential. And the way to basically do is that it will be able to antagonize the effect of another. So, it should be a full antagonist. Because if it is only partial, it means that it can actually also cause the euphoria. So, it will be very hard for you to stop. Something that is a partial agonist means that on one receptor it's an agonist, on another receptor it can be an antagonist. So On that receptor where it becomes an agonist, you'll still be feeling the euphoria, so you'll still be able to abuse. Okay, so naloxone is an example of such a drug that we get to use in these abuse cases, and also naltrexone. So naloxone and naltrexone. Naloxone, naltrexone. These are going to be used in dependency. Okay, 27 is saying the chemical mediator that is involved in control voluntary movement, regulation of autonomic nervous system, target organs, and the cognitive function is serotonin, norepinephrine, acetylcholine, dopamine. Which one can you pick? Which neurotransmitter is involved in voluntary movement, regulation of autonomic nervous system, and cognition? Acetylcholine, very important, all right? So if there is a deficiency in acetylcholine, there is actually a problem with cognition, trying to understand. You are studying, things are not making sense. You read like this, you read like that, and it's not making sense because you lack acetylcholine. It's not enough. So if you want to improve the cognition, improve some acetylcholine, right? Norepinephrine, this guy is sympathetic in nature. Okay, so 28 is saying breakthrough pain occurs between the dose of regular opioid therapy. Which of the following statement is true about the management of breakthrough pain? Patient can wait for the next dose of opioid analgesic as it is only for 1 to 3 hours before the next dose. Patient can be treated according to step 1 WHO analgesic ladder with paracetamol or NSAID. An opioid drug may be prescribed that has a quick onset, short duration, and easily administered. An opioid drug may be prescribed, but the patient can not take the next dose of the regular opioid analgesic drug. How about this one? What do you think? So breakthrough pain is the pain that occurs. Let's say you are being treated like you are in pain. You are given a drug to treat the pain. But even when you are on that drug, you are still feeling the pain. So how do you treat such pain when you're already on a drug to manage the pain? So what happens in this condition is you should give another drug to help you with the pain. But the drug that you give should work quickly and should be of short duration. Okay, and should be easy to administer. Those are the conditions. An 80-year-old man was brought to the emergency room after complaining of an inability to swallow food. The structure most closely linked to this dysfunction is inability to swallow. Which cranial nerve do you think has been affected? We are doing clinical skills, isn't it? I think we've done the central nervous system exam. Inability to swallow. What cranial nerve is involved? Or we did even head and neck. So cranial nerve number 9 and number 10. These guys are involved in that. And the nucleus that will be controlling that, nucleus ambicus, okay, that is going to be able to control the swallowing and such. It's a very big nucleus that controls many different things. I hope that's okay. When you look at the inferior olivary nucleus, that one will basically get to control signals coming from the cerebellum, or actually going to the cerebellum. Okay. The spinous trigeminal nucleus, that one it processes pain that is coming from the face. 30 is saying an inhibitory neurotransmitter that has sedative and convulsant neuroprotective effect is neuropeptide, adenosine, nitric oxide, serotonin. Now, Just them saying inhibitory. You know the inhibitory transmitters. If you are only how many? Is it three? Anyone who can name the three inhibitory neurotransmitters, the important ones? Yes. GABA, glycine, and which one? Substance P. Substance P really will not classify it really as an inhibitor, but adenosine. Okay, adenosine. So amongst these three, it's only adenosine that's there. So it becomes the answer. When you look at the other inhibitory neurotransmitters, like the GAB, the GABA. GABA is the main inhibitory neurotransmitter. Glycine also inhibitor in the central nervous system. And then there's excitatory ones a lot. You have got glutamate, you have got aspartate, acetylcholine, dopamine, epinephrine, and these others. Okay. 31 is saying which of the following opioids is used in managing labor pain? Important their labor pain, and biliary stones. Important their biliary stones because it is less respiratory depressing, causes less respiratory depression and biliary spasms. So I've got methadone, tramadol, pethidine, naloxone, or naltrexone. Which one do you think is the answer here? Pethidine, excellent. So yes, so pethidine is very good in that you can use it in pregnant women. Majority of these guys don't want to give them in pregnancy. And then also for biliary stones, because for the other opioids they actually cause the biliary tract to contract. So if you have got stones and then the biliary tract is contracting, it will cause more pain, but this one causes relaxation. Okay. And the biggest cause of death in people that take opioids is actually respiratory depression, and this one has got less effect on depressing the respiratory centers in the brainstem. 32 is saying which analgesic drug or drug class is used in step 1 of the analgesic ladder and has no anti-inflammatory activity. Has no anti-inflammatory activity. It's used in step 1. Paracetamol, NSAIDs. You have got the serotonin norepinephrine reuptake inhibitor and codeine. Which one do you think is the answer? Paracetamol, very good. So in the analgesic ladder, step 1, you use NSAIDs and paracetamol. Paracetamol is not an NSAID. It works on COX-3. COX-3 is found in the brain, thereby reducing pyrexis, reducing fever. And then you have got a 3, step 3. So at step 2, you are going to give weak opioids. At step 3, you can give the strong ones. The thing is that when you are giving opioids, you let's say you started at step 1. You always start at step 1. You can't go to step 1 before step to step 2 before step 1. And when you go to step 2, don't stop step 1. Okay, continue giving the drugs at step 1, but just add the drugs at step 2. 33 is saying which opioid drug is very lipid soluble and potent opioid analgesic and anesthetic. It is absorbed through the skin or inhalation and is one of the causes of the high rate of opioid deaths in the United States. Paracetamol, naloxone, stroke naltrexone, pethidine, fentanyl. Which one do you think is the answer? So every time you hear of these high deaths, yes, every time you hear of the high deaths, always remember fentanyl. Excellent, people. Thank you. 34 is saying the mechanism of action of inhalation anesthetic agents is now inhalation anesthetic agents fall under general anesthetics. So the general anesthetics are divided into the inhalational and you have got the IV ones. Okay, the inhalational ones, these include like nitric oxide, fluorine, isoflurane, you know those guys. Okay. So What is the mechanism of action basically of anesthetics? Opening calcium channels, deactivating chloride channels, blocking sodium channels, activating potassium channels. What do you think is the mechanism? So general anesthetics, okay, activating calcium channels. Thank you so much. Is there anyone that wants to give something different? Or we are good with A? There should always be room to debate. Okay. Another doc has said potassium channels. Is there another suggestion? Okay. So when you look at general anesthetics have got different and a lot of mechanisms of action. One of them is that they can work on potassium channels. When you open potassium channels, what will happen is that potassium will be leaving the cell, and so the cell is remaining negative, and that causes hyperpolarization, so difficult to cause uh, contractility, and of course, the formation of action potential that causes pain. Another thing is that these guys, general anesthetics, they can actually potentiate the effect of GABA. Okay, potentiate, in other words, to strengthen the effect of GABA. So GABA, what GABA does is that it actually opens the chloride channels. So B is not correct because of opening of chloride channels. Okay. If you open calcium, really, calcium will promote the release of neurotransmitter. So if that happens, it means that you actually have pain still happening. Okay. So the best option would be this one. Sodium channels is for local anesthetics, not general. If you hear blocking sodium, it is a local anesthetic, because if you block sodium, there's not going to be depolarization, and so there is no spread of action potential. Which drug is a prototype opioid drug with a strong analgesic activity? Morphine, naloxone, stroke naltrexone, codeine, tramadol. Which one is the prototype? What is a prototype opioid? A prototype is a drug from where we're going to get other drugs. So which is the opioid from where we get other opioids, or we synthesize other opioids? Morphine, excellent. 36. A chemical messenger released from a neuron at an anatomically specialized junction and diffuses across a narrow cleft to affect one or two postsynaptic neurons is called what? But take note of this. You are diffusing through a cleft. Okay, that's important. Neuromediator, neurohormone, neuromodulator, neurotransmitter. What do you think is the answer? And it's going to the postsynaptic neuron. So this is now what we've been discussing from second year, isn't it? Anyone? It's a neurotransmitter. All right. Excellent. 37 is saying Bambisky's response is usually present in disease of lower motor neuron, upper motor neuron, thalamus, cerebellum. What do you think for this one? Remember, we said Babinski sign. There's also what we call clonus. Hope you remember how to do clonus if you've done the CNS exam in clinical skills. So these are upper motor neuron signs if there's a lesion to upper motor neurons. Which of the following is true about WHO analgesic step ladder? When the patient does not respond to analgesic drug in step 1, the drug in step 1 are continued as more potent analgesic are added in step 2 and above. When the patient does not respond to analgesic drug in step 1, the drug in step 1 are discontinued as more potent analgesics are added to step 4 in step 2 and above. The drugs at the topmost of the WHO analgesic ladder are more potent and readily available, with fewer side effects than the drugs at the bottom of the ladder. Opioid analgesic drugs can reduce pain, fever, and inflammation. What do you think? Which one is the best option? Okay, A is the best. Thank you. So remember, as we said, you only give when you are giving the drug in the higher step in the analgesic ladder. You don't stop the ones below. And the reason as to why we don't go down to the ones on top is because they have got a lot of side effects. Okay, like euphoria, addiction. 39. Which of the following spinal tract involved? Which of the following spinal tract is involved with the control the trunk muscles? Vestibulospinal, ventrocorticospinal, laterocorticospinal, ventrospinocerebellar. So which one controls the trunk muscles? Any thought? Any thought? Okay, when you are controlling the muscles, when you look at the answers which are there, you have got the vestibular. The vestibular, these ones really are for balance. They are not really controlling the muscles. These are for balance, all right? But the corticospinal goes to control the muscles really. You have got the ventral and the lateral. So the ventral or the anterior corticospinal is a pyramidal tract and it to control axial muscles. Muscles of the trunk or axial, the ones on the midline. When you look at the lateral, the one that decussates, this one goes far to control the muscles that are distal. Okay, the lateral one. So that is that. According to the nomenclature of compounds, a group of alkaloids extracted from poppy seeds are called opioids, opium, opiate, morphine derivatives. Which one do you think is the answer here? A group of alkaloids derived from the poppy seed is opium, right? Yes. And then what's an opiate? What's an opiate? Okay, any agent from opium. And then opioid. Okay, so opiate is anything that has either been made or outside or made in the body that behaves like morphine. All right. So section B, draw a well-labeled diagram of the arterial circle of Willis. Now, you can't go in a test in neuroscience if you don't know this. They'll either give you a diagram or they'll ask you to draw. The and it's been like that. I think last year, test one, it was drawing. The exam, they brought a diagram. SAP, they asked them again to draw, I think. Okay. So expect anyone. So when you are drawing the arterial circle of Willis, basically start from here. You have got these two guys going like this. When these two guys go up, they are going to go like that. And then they are going to meet with, at this point, I'm going to write circles. And then in front, you also have these guys joining. Of course, they are going to come out like that. And then you have got a branch that comes out here, an important one, another one there. And then you have got a branch that's on top here, even here. Okay, and then here you have got a branch that comes to connect, to come down like that, which is important. And then you have got small ones that come out here. Of course, you also have another one that will come out here. Sometimes, this is sometimes, there's a branch that comes out from here. Sometimes this same branch will come out from this my big one here. Okay, so please just make sure you take note of that. And then there is this. Okay, there's also a common important one that we can draw here, like that. Okay, now I'm going to label these and then you'll be telling me what their names are. Let's start with, let's call this one. What is one? These two guys that go and join, what do we call them? The vertebral arteries. Excellent. And then let's have two. What is this one called? Mm-hmm. The anterior spinal. Yeah. Yes. So take note that the anterior spinal is only alone, and it's important for to understand that. Okay. Anterior spinal is only alone. Another thing that I've not mentioned is that from the same vertebral arteries, you also have arteries that will come out like that from the vertebral arteries. Let me label it as three. What do we call these arteries that come from the vertebral artery? S- Yes, excellent. So this is known as pica. Now the way the cerebellum is that it's big at the bottom, okay, and then it's smaller on top. So at the bottom it will be supplied by two arteries. You have got posterior inferior cerebellar, that's pica, and then anterior inferior cerebellar. So I've got in the front and at the back because the back is the bottom is very big, the inferior part. So I've got ica and pica. But the superior part is small, so it is only supplied by one artery there, only the superior cerebellar. Okay. And then let's have this one, this big branch that is coming just nearly where this big artery has been formed. That's where it will be coming out. What do we call that one? This is the one that's known as ICA, anterior inferior cerebellar, not cerebro, cerebellar. Okay. So sometimes from ICA, you can have this artery coming out. We call it the labyrinthine artery. It goes to supply the ear. Sometimes it will come direct from the basilar artery. So this one, this six here is the basilar. So if you don't label labyrinthine, I don't think they will remove some marks there. And then you have got this a lot here. What do we call these ones? The pontine artery is excellent. And then we have got this guy here that is going to now go and do the job that the other part of the cerebellum, the job that wasn't well done. What do we call this one? This is superior cerebellar artery. Okay. Superior cerebellar is a bit down. And then now you go to the cerebral arteries. So you have got this one. So let's start with this one. What do we call this one? The one I've labeled 9. So the cerebral, you have got three big ones. Yes. So this is posterior cerebral artery. You have got this one. What do we call this one? The middle cerebral artery. And then you have got this one. So starting from just this point, going all the way up like that, that's known as the anterior cerebral artery. Okay. We don't have superior cerebral. It's only anterior, middle, and posterior. The superior is cerebellar. And then these guys are coming from this structure. What is this structure here? This is the internal what? The internal carotid artery. Coming from the common carotid. And then this kamaga that is going inside, this one is going to supply the eye. So we call it the ophthalmic artery. So sometimes you also see on a diagram a artery that will come out like this. We call it a choroidal artery. Okay. So these are the main arteries. It's called the anterior choroidal, this one that I've shown behind. So these are the main branches. Okay, so make sure to take note of that. And then we have got this diagram. This diagram is showing us the cranial nerves. So we start with part one. Now this is the brainstem in case you don't know where we are. This is the brainstem. For the brainstem, remember we start with the midbrain, the pons, and the medulla oblongata. So what is one? This structure is part of the three structures of the brainstem. Is it the midbrain? Is it the pons? Or is it the medulla oblongata? It's a pons because just below the pons we have got the medulla oblongata. Now on the pons, in front of the pons, you have got this cranial nerve. It is only alone like that. What do we call that cranial nerve? Okay. So the trigeminal nerve, isn't it? Now for the trigeminal nerve, we have got the sensory and the motor root. So we have got motor medial one some okay motor is medial. All right. This comma one which is medial is the motor motor medial and it is small. It's different from the facial nerve where the one that is going to be small is the sensory. Okay, hope we get that. So the big one that has been labeled, that's the sensory root of the trigeminal cranial nerve number 5. And then what is number 4? This space that is on the middle in the medulla, what do we call it? Yes, the anterior median fissure, right? Or the ventromedian median fissure. And then on the sides of the ventromedian fissure, we have got this structure. What do we call it? This elevation, the pyramid. And just behind the pyramid, we have got another elevation. Okay, what do we call the elevation behind the pyramid? That's known as the olives. All right, the olives. 7 is showing this structure on the pyramids where decussation happens. What do we call that part? A point of decussation of the pyramids or pyramidal decussation, right? What has been labeled as 8 there is just showing the supposed to point at the canal here, what we call the central canal. That's 8. So we can now label the cranial nerves. Now, when you are labeling these cranial nerves, you start from here. The first one, between the pons and the medulla, the first cranial nerve there is cranial nerve number 6. And then you'll be following the numbers. So I've got this is cranial nerve 10 is cranial nerve number 6 of the abducens. And then when you go to 12 and 13, that is cranial nerve number 7. But remember, one is motor, one is sensory. So I already mentioned. So which one do you think is motor? Is it the small one or the big one? Anyone? If for this one here, the trigeminal, the motor was small. Yes. So 12 is going to be what? What is 12? Of the facial nerve, isn't it? Remember, cranial nerve number 6, cranial nerve number 7, cranial nerve number 8. That's how they move. Okay. So 14 is going to be cranial nerve number 8 there. In case you've forgotten the name. Anyone to remind us the name of cranial nerve number 8? Or we've forgotten? Vestibular cochlea. Right? Vestibular cochlea. Now, we have got these fissures, we have got this space here. It is in front of the olives. This space is in front of the olives. So we call it the pre. olivary fissure. And then behind the olives, we have got another space, which we call the post olivary fissure. So you have to understand these two fissures. The pre olivary fissure, you have got cranial nerves there, and then the post olivary fissure, you also have cranial nerves there. And the way these cranial nerves move is that they are going to start from the top, and that's how we are going to be naming them going downwards. Okay, going downwards. There's only one cranial nerve that is alone, and it is actually in the pre. So the pre-olivary fissure, this cranial nerve that you can see here in the pre-olivary fissure, is just alone. What is the name of that cranial nerve? It's just alone. Yes, the last cranial nerve number 12 is just alone in the pre. And then in the post-olivary fissure, you now count them. You start from, remember this was 7, 8. So you now start 9, 10, and 11 down. Okay, that's how you number them. 9, 10, and 11. So this one, that is the downmost, is going to be 11. But remember, cranial nerve number 11, the accessory nerve, has got the cranial part and the spinal part. Okay, the cranial part and the spinal part. So the one that is more down is going to be the spinal part. And then this one that is a bit on top, because you can see the fibers actually a lot. The one that is on top is the cranial part. The one down, because coming from the spinal cord, that's a spinal part. Okay, hope that makes sense. Okay, so that is that. And then we have got number 17. So number 17, that is the accessory nerve, because you've now combined the spinal root and the cranial root of the accessory nerve. Now you have formed one, so we just call it the accessory nerve at that point, number 17. And then you have got which one? You have got 16. 16, remember we said that on top of cranial nerve number 11, you have got cranial nerve number 10. So 16 therefore is going to be the vagus. Okay, the vagus, and it has got a lot of roots also. So that is this diagram. Is there anything that we've not labeled? And I hope we've understood. Does this make sense? So for the brainstem, you need to know how it looks in front and how it looks at the back and how it looks inside, the internal features of the brainstem. So going down, this is again the brainstem. Okay. But for the brainstem, the pons, the medulla, and the midbrain, when you just see what looks like a short, you can see a short here. That's a midbrain. Okay, that's a midbrain. Every time you identify a short, it's the midbrain. Now, the midbrain is divided into two parts. You have got the middle like that. You have got the front and the back. I think at second year you had learned that the midbrain has got four parts. Let me start for you. Take term. Anyone to mention the next part? After take term, we don't remember. Take term, tegmentum, crus cerebri, and the substantia nigra. Okay, so those four parts. So it is when you look at the front part of those parts that I've mentioned, the tectum is posterior. Okay, the other ones are going to be more anterior. So what has been labeled as 2 here, that's a posterior part, that's a tectum. This part is the tegmentum. This part is the crus cerebri. The substantia nigra is a dark area. It's a dark area, and it is this area here labeled number 9. Substantia nigra has got two parts. There's what we call the pars compacta and pars reticulata, reticularis. The importance of this is that this guy, actually the pars compacta, contains neurons that contains a pigment that is deep or rich in dopamine. So in Parkinson's disease, there's going to be degeneration of the pars compacta. So dopamine neurons are lost. Because of the loss of those dopamine neurons, there is more acetylcholine, less dopamine. That's what causes the symptoms of Parkinson's disease. Therefore, treatment, you replace dopamine and you reduce acetylcholine in Parkinson's disease. Okay. So having mentioned that, let's again start on the front part. So for the front, you can see we have got these three parts. This one, and this one, starting from the front. So the front most we have got the frontopontine fibers, and then we have got the cortical, spinal, and cortical nuclear fibers on the middle, and then temporopontine fibers. So frontopontine, frontopontine, this one, and then corticospinal and corticonuclear, and then you have got this one at the back, which is the temporopontine fibers. Okay. One thing that you'll be able to quickly see is this cranial nerve that moves in front. We call that as cranial nerve number 3 because cranial nerve number 4 comes from the back, but this one is coming from front. Front, that's oculomotor. If it was coming from the back, that would have been the trochlea, right? And then another important structure that you'll be able to recognize in the brainstem is this big part. We call it the red nucleus. Okay, the red nucleus. Hope that makes sense. And then you have got tumor fibers that decassette. So fibers that are coming from the red nucleus going to the spinal cord. You can see these fibers going like this, labeled 14. Those are the rubro spinal. They come coming from the red nucleus, going to the spinal cord. Because they are decasseting, we call them decassation of the rubrospinal tract. Like they are turning directions. Remember also, we did this. We talked about hydrocephalus. The causes of hydrocephalus can be either congenital or acquired. One of the congenital causes is those conditions like anode-Curie malformations. And then for the acquired, sometimes you can just have where this gamma structure is just obstructed. So fluid is, cerebrospinal fluid is accumulating above. So we call that the cerebral aqueduct of Sylvius. Structure number 4. Structure number 3, that's what we call the superior colliculi at this point. Okay, this one. And then we have got the area around the cerebral aqueduct of Sylvius. We call it the periaqueductal gray, the area that is surrounding the cerebral aqueduct of Sylvius. Okay. And then we have got a nucleus, this nucleus labeled 6, that one. That nucleus is the mesencephalic nucleus. Remember, mesencephalic just means midbrain. Remember when it comes to the development, we had the proxencephalon, mesencephalon. So this is the mesencephalic nucleus. It is of the trigeminal nerve. So mesencephalic nucleus of the trigeminal nerve. Okay. And then we have got this part which we call the lemnisci. This is structure around. And then we have got a part that is labeled 8 there. So the part labeled 8 is the medial longitudinal fasciculus. It's a fasciculus, medial longitudinal fasciculus. Is there anything that we've not labeled? So we've labeled basically everything, isn't it? Okay. There is also which one? There is 13. This structure that is around the periaqueductal gray, and we call that one. Remember, that's where the oculomotor is coming from. That's the nucleus of the oculomotor. So oculomotor nucleus. Which other part is not been labeled? I hope I'm not pointing at the wrong part. Actually, 13 is pointing at this structure. That is the red nucleus. The oculomotor nucleus, I think, is this one that is going like that. Okay. And then 15 we had already labeled, that's the oculomotor nerve. So those are the parts which are here. Is there anyone that's behind? And then we have got this diagram. Okay, I think this come a part we can all answer. What is this part? It is the area that is in front of the central sulcus. What is the name of that area? Anyone? Areas of the brain. Are people able to get me? Look, guys, when you have got the brain like this, and then you have got this central canal or central sulcus, you have got the gyrus in front and the gyrus behind. The gyrus in front, what do we call it? And the gyrus at the back. One is motor, one is sensory. Just that. So three is the B, the one I've labeled B is the somatosensory cortex. Okay, somatosensory. That's why I've got what we call area 312, Broadman area 312. And then A is the motor area. Okay, primary motor cortex. That's where this tract is coming from. It is motor in nature. It is a descending tract. So what tract do you think is coming from the cortex, the motor cortex? Any descending tract that you know that reaches to the spinal cord? Nothing. So 2 is the motor cortex. Yes, the corticospinal. So 2 is the motor cortex. The 3 is known as the internal capsule. We'll discuss it. The internal capsule makes like a V, like it makes a structure like this. This is where the fibers of the corticospinal get to pass as they come from the cerebral cortex. And then we are going to be going downwards. And you can see that it has been divided into the spinal cord, or this region has been divided into different areas. You have got the medulla. Even this is the medulla because you have got medulla is at different levels, and then the pons. So what part is above the pons? What part of the brainstem is above the pons? What is for? Brainstem has got three parts: pons, medulla, and which part? The midbrain, all right? The midbrain. Okay. Which other one can we label first before others? Okay. We can go to 5. So in the midbrain, we have got a structure labeled as 5. So the midbrain is connected. Remember, this is actually showing the back. The midbrain is connected to the cerebellum. Via what structure? Anyone? What's the name of the structure that connects the midbrain to the cerebellum? So I've got midbrain on top, and then we have got the pons, medulla. These three structures are connected to the cerebellum like that. So what's the name of this structure that connects the midbrain to the cerebellum? We call it the superior cerebellar peduncle. Okay, so 5, that's that. Also known as the basis pendiculi. And then we also have the basis pontis because that will be now in the pons. That is 6. Okay. And then going to 7. 7, you can see that is the area where the tract is passing. This area where the tract is passing. And this is in the medulla. So the corticospinal tract passes in what we call the pyramids in the medulla, and that's the area labeled there. And then continuing downwards, we have got 8. You can see there's this tract and then it has decussated to the other side. So that is decussation of the pyramids that has been shown there. And then so that is number 8, decussation of the pyramids. And then we have got number 9 and number 10 also. Where are they even pointing to? Okay. I hope they are just showing they just mean this track that is supposed to be going this side. I'm not really seeing where the arrow is, wherever they are pointing to. But you have got the fibers that are running. You have got the tract here that after decussation, the tract, remember the corticospinal, after decussation, the tract that remains is the anterior corticospinal. So this structure here is anterior corticospinal. The one that goes this side is the lateral corticospinal. Okay. And all these guys are going to the muscles, so to the motor end plate. And then you have got this structure again. It's another descending tract. You can see even the areas where this guy is going to pass as you get to go down. Okay. Actually, this one is really not descending. The way you tell is you are going to look at the nerves. If you have got 3 nerves, then that's not descending at all. It's ascending because the descending fibers only have 2 neurons, the lower and the upper. But look at this. It starts like this, it ends here, and then another one picks it up from this side, and then it's going up. Look at how it's going. It's going up, and it also ends here. Where has it ended? Yeah, it ends somewhere here, and then from here another one has picked it up. So it's just that the diagram is not that clear, but that's how it is. You can see 3 neuron systems. So this is not descending, it's actually ascending. So what has been labeled as 7 here, what's the part here? You have got this structure here. Now at this point, of course, you can't understand because this is part of what we call the basal ganglia. So 7 is what we call the corpus striatum, part of the basal ganglia. Okay. And then number 8, where is 8 pointing? I don't know if he's pointing here. So if he's pointing at that point, that is where the fibers that go up, like that white area, we call it the internal capsule. This white area here, this white area, that's the internal capsule where the fibers will be passing through as they get to descend, going downwards. And then this area that has been pointed to here, down here, within the basal ganglia, is where you also find the thalamus. So number 6 there is pointing to the thalamus. Specifically the thalamus where the ascending fibers come from the spinal cord are going, that's the ventral posterior lateral nucleus. So if you want to be specific, the ventral posterior lateral nucleus or the thalamus. And then you have got the midbrain at this point. So you can see the different parts of the midbrain. Earlier on we had mentioned the parts. You can already tell what this structure is for the midbrain. Okay, so that is a crus cerebri. Crus cerebri. And then this gamma structure here is what we call the red nucleus. That's 5. And then 9 is the medial meniscus. And then 4, this is just trying to label which part now have we reached at. when you come from up from the midbrain, where we reached. So this is the pons. That's the structure at which we are now. And then going down up to 3, what structure, what fibers are those which are going upwards? So we call that as a spinothalamic tract. Okay. And specifically, look, it is coming from this side. This is lateral because the anterior spinothalamic tract is somewhere here. So 3 is the lateral spinothalamic tract. 1, you can see this kama, this is a first order neuron, and that's the dorsal root ganglia. That's a first order neuron. Okay. And then we have got this part where decussation gets to happen here. We call that part as the ventral white commissure, where this guy will be able to pass to go to the other side after decussation. Ventral white commissure is part of the white matter where decussation gets to happen. And then you have got, this is just a posterior aspect of the brainstem. So you see that you really need to know the brainstem, starting from the posterior aspect, the anterior aspect, including also the internal features. Okay. Now this diagram is not just so clear, so I don't want to us to really look at it because it's a bit of more dark. So even if I point at them, we'll be now assuming. So I'll show you just a clear picture. And then this is representing the facial nerve. The facial nerve. If we start from here, this is an, I think this is clear. You can see that's a Kamatia gland, and we call that one what? What's a should I say scientific name, or what is the other term that we give to tear glands? Anyone? The yes, the lacrimal. So that's a lacrimal gland. This nerve that is going to the lacrimal gland, what do you think is the name? It's going to the lacrimal gland. What do you think? It's the yes, lacrimal nerve. And then you have also this nerve here. This is the maxillary nerve. Okay, number 9. That's the maxillary nerve. And then coming back, you can see we have got this structure that is hollow. So when you are forming these branches of the facial nerve, they are really interesting because when you join some nerves, when you join what we call the greater petrosal nerve with the deep petrosal nerve, you form what we call the nerve of the pterygoid canal because it is in the pterygoid canal, and that's the 6, nerve to pterygoid canal. This is a greater petrosal nerve, number 5. 7 is a deep petrosal nerve which comes from the deep petrosal nerve comes from the internal carotid plexus. Okay. The nerve to pterygopalatine canal is going to go on a ganglia. On a ganglia. This ganglia here. We call it the pterygopalatine ganglia. And then as we go much even backwards, you can see we have got this structure here. Okay, sorry, just a moment. All right. So what we are calling as 4 here, we call it the geniculate ganglia. Okay, the geniculate ganglia. Now, when you are coming, because cranial nerve number, which one is this? Cranial nerve number 7 has got different roots. Okay, so you are going to have the main motor root and then what we call the nervus intermedius. So this one here, these fibers that will be going up, that's the nervus intermedius. Okay, and then what has been labeled as a 3 there is going to be the motor root. And then these guys will actually enter in the internal auditory meatus. That is the one that has been labeled there as a 2. So we are now going to, so from the internal auditory meatus to go to the geniculate ganglia. This is where now we're going to have the greater petrosal nerve coming out, and then you're also going to have this branch that will come down to give you a lot of branches. So let's first follow this branch that goes like this. You can see it is going to some, you can see these structures. These are also other glands. Okay, so this branch we call it the coda tympani. This is the coda tympani 16, and you can see it is joining some fibers that are coming from here. So the coda tympani is coming from the from the facial nerve. It moves together with a branch that comes from the trigeminal nerve, which we call the lingual nerve. So 12 is the lingual nerve, and then they are going to go and supply like the anterior 2/3 of the tongue, and also supplying other structures. Okay, so we have got 15. So 15 there is a ganglion. We call it the submandibular ganglion. That supplies two glands, salivary glands, the submandibular, which is big, and sublingual. So this is submandibular, this one is sublingual. And then there's also a nerve that comes out here while you are within the ear. We call it the nerve to the stapedius muscle. Okay, that is 17. And then you continue like that. This guy is going to move out. The nerve that remains in the ear is going to now come out via that opening, which we call the stylomastoid foramen. So that is 26, the stylomastoid foramen. When you look at what has been labeled as 27 and 28, that is showing us there are some other branches, the vagus nerve, the branch of the vagus nerve that goes to the ear. So that is the auricular branch of the vagus. Okay, so that is the auricular branch of the vagus because going to the ear, this one. And then the nerve itself, that is ear 27, that's the vagus cranial nerve number 10. And then further you can see there is this branch that will come into this gland. So you have got actually a gland here. What gland do we see the cranial nerve number 7 starting to bifurcate in, or starting to divide? It's a parotid gland. Okay, so 23 is parotid gland. It's in the parotid gland that the facial nerve will give you the 5 many branches, which they say to Zanzibar by bus. To Zanzibar by bus. So temporal branch, zygomatic branch, buccal branch, mandibular, and the cervical. To Zanzibar by bus. So temporal, and then zygomatic, buccal, by bus. To Zanzibar by bus. And then you are going to have the mandibular branch and then the cervical branch. Actually, we say to Zanzibar by motor car. To Zanzibar by motor car. This is going to be the cervical. And then there are also these other branches that go posteriorly, not really posteriorly, but that will give you other innervations. You have got the nerve to the posterior belly of the digastric and this stylomastoid. This is the one, the nerve to the posterior belly of the digastric and the stylomastoid. And then you have got the posterior auricular branch. Okay, the posterior auricular branch, which is 25. That's the posterior auricular. So these are the branches. And then section C is saying which opioid drug is used in management of mild to moderate pain, cough, and diarrhea. So it's an opioid. You use it for mild to moderate pain, cough, and diarrhea. So you can also use it for cough. That's codeine. It's not so strong. Okay. Exogenous and endogenous compounds with morphine-like properties. What do we call those? Those are the ones we call opiates, isn't it? All right. Actually, not opiates, but opioids, because opiates are those that are just derived from opium. These are opioids. And then an opioid that is more potent than morphine, but clinical use is limited by a high risk of euphoria. So something that is more potent than morphine, heroin, also known as dimorphine, is very potent, but it has got euphoria, so we don't use it. The commonest cause of death in opioid overdose is respiratory depression. Term used to describe reduction in opioid analgesic efficacy after prolonged use. So after prolonged use, it becomes less efficacious. That is it. Tolerance, isn't it? Okay. The signs and symptoms of opioid withdrawal are like the organophosphate poisoning acronym dumbbells, except for tachycardia. And for organophosphate poisoning, it's just different from opioid withdrawal, like when you're trying to stop. Okay. In that, there is tachycardia and hypertension, which are not in dumbbells. Group of non-opioid analgesic drugs used to treat dysmenorrhea and fever. So for dysmenorrhea, pain during menses and fever, you use NSAIDs. The FDA-approved opioid drug for treating transmucosal fentanyl citrate pain includes oral. So for treating transmucosal fentanyl citrate, so that one is okay. The FDA-approved opioid drug for treating transmucosal fentanyl citrate pain includes oral dash. Okay, I think this one, the way the question has been written, there should have been a space somewhere. So the FDA approved drug for treating dash transmucosal for treating dash pain includes transmucosal fentanyl citrate. So for treating dash pain, so yeah, that's how it was supposed to be. So it is breakthrough pain. So transmucosal fentanyl citrate is going to be used for treatment of breakthrough pain. A fetus cannot metabolize morphine and is metabolized due to the lack of which enzyme? So there is a cytochrome P2D6, CYP2D6, CYP2D6. Then we have got the extended matching question. So you have got GABA receptor agonist specific opening of the chloride ion channel, selective blockade of calcium ion channel, non-selective through blockade of inhibition, intravenous general anesthetic agent, non-specific reduced chemical mediator. So we should match with these scenarios. Activation of glycine receptors associated with what? So if you activate glycine receptor, you get to open the chloride channel, so it is C. Okay. Activation of potassium channel is a mechanism of action of, remember, for potassium channels, it is the general anesthetic, so intravenous general anesthetics. Non-selective CNS depressant produce their effect via. So the CNS depressants, you want to, because what they do is that they are going to activate the receptors for GABA, and GABA will basically reduce the release of other neurotransmitters or chemical mediators. A drug having an effect on only one molecular target at low dose but acts on more than one molecular target when the concentration is increased is said to be. So such a drug, it works depending with the concentration. We call such a drug as being selective. Something that is specific, it doesn't matter the concentration. And then 6, the mechanism of action of GABA receptor agonist is via. So GABA receptor agonists, drugs that work stimulate GABA receptors, will actually get to promote the opening of chloride ion channels. Okay, so that is it for this paper, and thank you so much for being present. The diagram that I said I'll just show us how to label because it looks not too clear is this one. Okay, so you can see that one there. Thank you so much. Have a good day.